Infections Consortium, which is a federation of clinical researchers that was set up after the 2009 influenza pandemic to try and improve the standards of clinical research undertaken during epidemics. We're delighted to host this webinar, and it's our first webinar that specifically partnered with Russian colleagues who are partners in ISRIC. ISRIC has partners across the world, and we are open to any clinical research network that studies infectious diseases, and it's really a grassroots federation of clinical researchers. So there's no agendas, it's just a forum for sharing our expertise and experience and finding like-minded researchers across the world to conduct research. We've got a really nice agenda for you today. Previously, we've looked at pharmaceutical interventions for COVID-19, but today we're going to be focusing on ventilation strategies, particularly non-invasive ventilation strategies. Now, I have to confess I'm out of my depth here. I'm an infectious diseases person, not a critical care person, but it's very clear that the mechanisms and methods of respiratory support are really important. What we've seen, I think, is declining case fatality rates over time as we have more experience around managing patients with moderate or severe COVID-19. And part of that, I believe, is due to improvements in how the respiratory support is managed. So we've got a really nice selection of speakers from Russia and from the UK and elsewhere going to be speaking on their experiences and guidance that's recently been reported and also studies that are ongoing. Now, for those of you who wish to, there is translation into Russian. And if at the bottom of the screen on the right-hand side, there's a little sort of world icon where you can click to get interpretation into Russian, and thank you to our interpreters. And then we're trying to have this as an interactive session. So if you have any questions, please post them in the Q&A section of this webinar. And to do that, you click on the Q&A box in the bottom right-hand corner and type your questions in there. And then we have two online moderators who will be looking at the questions, answering them, or passing them on to the speakers to respond to. So welcome and thank you very much everyone for joining us. I look forward to a really exciting session, and hopefully this will be the start of some interactions between people who wish to take forward this area of research. So I'd like to now hand over to Dr. Daniel Mumblett, who will introduce the rest of the programme. Thank you.
Thank you very much, Peter. Thank you very much for a kind introduction. And it is really a pleasure to be here and to be a core organizer of this wonderful session with ISRIC. And I would like to give a very brief outline of what was done here at Sechenov University in collaboration with ISRIC. I think that it's really a wonderful international initiative which allowed us really to set up a cohort. Fortunate to be a Stop COVID cohort lead. And this is a unique time when international cooperation really shines, because before COVID, sometimes it takes a lot of time and complexity, but during COVID pandemic is really a truly global initiative for bringing people together. Could you have the next slide, please? Yeah, thank you very much. It's just the this illustration from the Science Journal from one of the colleagues, which illustrates the difficulty of teaching during pandemic. But I normally use it now to show how activities, research activities work nowadays. And that's what we've done in the very beginning of pandemic here in Moscow at Sechenov University with the Sechenov University cohort. And we did it remotely. So it's quite a task. And I'm just giving a 5-minute, very brief introduction to the next talk, which will outline the work that had been done in our cohort here in Moscow, passing to the medical student. I think that it is extremely important to promote the work of medical students that have been done. If you look at the JAMA papers, if you look at the BMJ papers, Lancet papers, you will see how heavily students were involved in this work. So in our cohort here in Moscow, we brought on board 44 to 6-year medical students. Could you please click again and again twice? Thank you. And we brought also multidisciplinary expert team, and obviously we're thankful for the full administrative support from the university. But I would like to highlight that this work was done predominantly by medical students. They did extraction, they interviewed people, and I think that we should not forget that they are really the driving force of research in many countries. If you please click to the next slide. Thank you very much. And ISRIC was very supportive from the very, very beginning of the pandemic. They provided us with the protocols, and it's really a pleasant experience for us to collaborate with ISRIC and partners from all over the world, and particularly from the UK, where ISRIC headquarters are. Due to this collaboration, we really managed to set up a very good and well harmonized, well characterized cohort here at Sechenov with 4,500 patients described in detail and followed up. Please could you click to the next slide. And as I said, all of this is just because of our medical students. And I think that I really urge everyone who joined this session, our collaborators from ISRIC and from other countries and from Russia, students should be promoted and students should be acknowledged for what they're doing. And of course, I could have been given a talk on our core, but I think that it would be much more necessary for our students to present, to show the work that they have done, and the work, the input that they've done over the months, and that they continue to commence their time to research activities. I would like to pass over to the chair of today's meeting, Dr. Anne-Marie Doherty. She's an academic consultant in critical care in Edinburgh, and she's interested in identifying different risks in heterogeneous populations. And since the arrival of COVID in the UK, she has been leading the data analysis for ISARIC 4C in the UK. So over to you, Anne-Marie.
Thank you very much, Daniel. So we've got a fantastic array of talks coming up over the next hour and a half. Each speaker is going to introduce themselves and then move on to the next speaker. I would encourage you, if you have any questions, to put them into the chat box as early as possible, and we'll try and answer them and discuss them as we go through. So without further ado, I would like to hand over to our first speaker, who is Dr. Ben Messer, a consultant from the RVI in the UK, who's going to talk about non-invasive ventilation for patients outside the ICU. Thanks very much.
Thank you very much. Thanks, Anne-Marie, and thanks for asking me to speak today. As Anne-Marie says, I'm a consultant in critical care and home ventilation, and I've been involved in guidance about respiratory support in my role as chair of the Critical Care Specialist Advisory Group at the British Thoracic Society. So I'm just going to take you through what we've done. I can't seem to advance the slides. Oh.
I think, Ben, you can just ask next slide, please, and they can be advanced for you.
Yeah, okay, if it's good enough for Boris Johnson, it's good enough for me. Next slide, please. Okay, so essentially, I'm going to present a little bit of the background to why we've done this, and also sort of take you through a little bit of the journey through COVID that we've had. I think a lot of people will remember the initial guidance from NHS England about non-invasive respiratory support. This was back on the 26th of March, and it was during what I look at as the panic phase of COVID, and we were all panicking really about this disease. We'd seen some awful data from Italy about patients who'd gone from 2 litres of nasal oxygen to being peri-arrest within a very short period of time. And the guidance was very clear. It did not recommend, in fact, it specifically recommended against high flow nasal oxygen and suggested a trial of CPAP for a maximum of 30 to 60 minutes with very early intubation, ventilation and invasive ventilation. If I could have the next slide, please. I think during the first wave, and then certainly during the second wave, because of some good results reported with non-invasive CPAP, and this is something from up in Newcastle, looking at patients who are not for intubation with a 50% survival. Because of this, I worry that we'd become a little bit blasé about CPAP and non-invasive forms of respiratory support in UK hospitals. And if I could have the next slide, please. One of the things that we found that's shown this more than anything is with Recovery RS, we were previously just recruiting people from a critical care setting, but now we're recruiting people mainly from respiratory wards. So we're getting more sick patients on respiratory wards than we were during the first wave. And you'll hear, I think, a lot more about this fantastic study, and one of the most important studies since I've started critical care a little later, from Bronwyn Connolly. Next slide, please. However, we anecdotally up here, but also around the country, have seen problems. We've had nursing staff who are not normally respiratory trained brought into respiratory units, and we've had a couple of issues where patients have not liked the feeling of the flow from the exhalation port, and they've been covered up. So there is an issue about training of non-specialist teams. Next slide, please. This is a perennial data from our trust, where essentially the first bar is the most important, that shows that 20% of patients who are on long-term NIV at home are mislabeled as being on CPAP. Next slide, please. And there are anecdotal data nationally that I hear that support this, but there's also NRLS data about patient safety. And here, during COVID and before, there's been a patient safety alert about misidentification of CPAP and NIV, and patients coming to harm because of this. There's also been some other studies published about CPAP suggesting that the outcome maybe isn't as good as we thought, and mortality rates of up to 80% are reported. Next slide, please. Some people may recognise the lack of governance about high flow nasal oxygen in the UK, and a little bit of a plug for our survey that we're currently doing to allow people to have their say as to what their experience with high flow nasal oxygen is. I'm certainly approached regularly on critical care by outreach who say, we've got somebody on a surgical ward who's on 70% on high flow nasal oxygen. And this unfortunately is a relatively common occurrence. Next slide, please. We know that we've had resource limitation has been an actual and theoretical problem during COVID. And we also know that the FICM, the Faculty of Intensive Care Medicine, have produced guidelines earlier this year, supported by NHS England, that have looked at enhanced care, so delivering just under critical care in a ward environment. And this is something that enabled us to build on what we're doing. Next slide, please. So between the British Thoracic Society and the Intensive Care Society, we co-released guidance about the respiratory management of patients with acute hypoxic respiratory failure with COVID. And the main point of this was to get people who were on 60% oxygen off non-respiratory wards. Next slide, please. This is the flow chart, which only looks busy because it's on a small slide. Next slide, please. And the key thing about this is that if you're requiring more than 40% oxygen or more to deliver your SATS target, and the asterisk there reflects that actually not everybody needs a target of 94%. We chose 94 because that's currently BTS guidance, but in higher risk groups that will be revised down to 88 as per BTS guidance. But if you can't maintain SATS of 94%, then you should be transferred to a respiratory support unit or somewhere that understands how to manage unwell patients from a respiratory point of view. At this point, you can either go for a trial of CPAP or high flow nasal oxygen, but preferably you should be recruited into recovery RS if you are suitable for escalation. Next slide, please. And here, if you can maintain SATs within your target, you continue to monitor. And if you can't and you're appropriate for escalation to critical care, then you should be referred. Next slide, please. We're going to develop these guidelines. We've given them some context in that we talk a little bit about what a unit should have in terms of staffing and particularly in terms of escalation policy. But what's very striking is that there isn't the governance structure for high flow nasal oxygen, for CPAP, or for any other respiratory intervention other than NIV, where there are fantastic guidelines. This is one in 2016, again, a close collaboration between the BTS and the ICS, the 2018 BTS standards. Next slide, please. The formidable NC pod report published in between those two documents in 2017. And we've been given some context to issue guidance in the future about exactly what a respiratory support unit should look like and what standards it should meet by these excellent standards published by the Faculty of Intensive Care Medicine. Next slide, please. So just to sum up, I think that there is a real issue, both locally up in Newcastle, but nationally as well, with the governance structure and safety of delivering complex respiratory interventions in a non-respiratory setting. And I think there's an urgent requirement to bring up the standard of safety and governance within this area of medicine to the standard that we see in acute NIV. And the BTS will be working with the Intensive Care Society over the next few weeks to publish those that guidance and standards. Thanks very much.
So thank you so much for the excellent presentation. And my name is Nikita Nikludov. I'm a final year medical student at Sechenov University. Very grateful to the managers and the speakers of the forum to have input their valuable time into shaping this inspiring event. And today I would like to start off by telling you about the Stop COVID cohort study that I helped coordinate, and that resulted in clinical and laboratory characterization of patients in Russia and allowed us to form the largest cohort study in Russia available until now. Just a moment. Yes. So today we're just briefly going to go through the methods and management structure that we shaped, then look at the results of the study, and then discuss future prospects of the project and define key points of the presentation. So the study that I am reporting now was published in October in Clinical Infectious Diseases. And just circling back to what Daniel said in the beginning, 40 out of 63 co-authors of the paper are current medical students or young resident doctors who were involved at all steps of the execution of the study. So these students and young doctors stand behind all the data collection that had to be completed, of course, in an emergent situation during a very short time. So data collection included a number of modules outlined on the slide. We collected data from consecutively hospitalized patients at Sechenov University Clinical Center comprising 4 large hospitals. And we use locally installed research electronic data capture, shortly REDCap, that is now integrated into further clinical research within the institution. So the collected data was then retrieved and collated with a global database through Infectious Diseases Data Observatory, so through IDDO, and was made available for partner analysis within the ISRIC consortium, which made Russia one of the major data contributors for these analyses. So the study was pretty simple in its methods. So let us now look briefly at the results that we saw. So the baseline characteristics of the Russian cohort are quite different from the ones reported worldwide by a number of factors. And firstly, our patients are significantly younger than those in the existing cohorts, with 56 being the median age of hospitalized patients. Another important difference is that our cohort included both clinically diagnosed and laboratory confirmed cases. So as you can see, about half of the patients actually were tested at least once and had not had a single positive RT-PCR result at any point in time. So as for the clinical characteristics, the symptoms on admission were quite similar to the worldwide data, as you can see, with fever, fatigue, or malaise, and shortness of breath being the top 3 symptoms found in hospitalized patients on admission. The same applies to the comorbidities, with hypertension, obesity, and chronic cardiac heart disease being the major players here. So which is pretty much in line with the worldwide data that has been reported. We observed the same trends with regard to laboratory markers associated with in-hospital mortality found in the complete blood panel, coagulation profile, and the metabolic panel. And here you can see only the ones that were associated with the p-value less than 0.001. And as for the clinical outcomes, we observed a quite low mortality rate, about 5%, but there are a number of reasons why this could happen. So firstly, it could be the lower median age of patients that were admitted. It could also be explained by the lack of a concrete message by the authorities, especially at the beginning of the pandemic, when the data were collected. Also, it could be explained by health-seeking behavior that is quite characteristic about the Russian patients. And this is the pivotal part of the study, is that we observed absolutely no significant differences between laboratory confirmed, so U071, and clinically diagnosed or suspected cases. So this drove our decision to include all of the patients into the cohort. And we observed no differences in any of the modules that we incorporated into the analysis, that is symptoms, comorbidities, CT scans, laboratory markers, etc. So we hypothesized that including just the confirmed cases could maximize selection bias. So this is why we made that decision at the time. And lastly, clinical factors associated with mortality are also in line with the worldwide data, of course, with chronic kidney disease, diabetes, and dementia, despite quite the wide confidence interval due to the sample size, but otherwise the data are very similar to the cohorts reported otherwise. And pertaining to the discussion that we are having today concerning the supportive care and outcomes, in our cohort, we observed quite a low rate of ICU admission and relatively high mortality at the ICU admission. But here it's important in patients that received ICU care, I mean, but it is important to understand that in within an epidemiological study, when we look at these variables as just the categorical, whether they were admitted or they were not, we did not include into the analysis any further details as to the length of stay in the ICU or the type of care that they received in the ICU. So these results only provide an overview and should not be open to too much wide of interpretation. And the non-invasive ventilation was also highly available in the COVID wards that where patients were hospitalized, and obviously we observed a lower mortality rate in this group of patients. And lastly, this information about the cohort is important in two ways. So the firstly is the team structure that Daniel highlighted. Most of the work has been done, of course, under the supervision of the scientific advisors and Dr. Mundlet as the lead of the projects. But currently we're having a team of about 100 students collecting data across 4 clinical centers. That is not just at Sechenov University, but also at other centers to bring to life some other projects that I'm going to be speaking about at the next slide. And we have a team of 9 senior students that are members of the coordinating unit. And this has, of course, become possible due to the immense help of the university administration that we have had here. And some of the ongoing projects that are of particular importance are the, so firstly is the long COVID, that is the long-term follow-up of the current cohort. And this is where the knowledge of the profile of this patient becomes important. We have already, so the team of students has already interviewed all patients from that cohort over 60 years of age. We also have, we are also conducting 2 projects, one dealing with multi-system inflammatory syndrome, which also contains some of the unique data with 2 follow-ups for each patient and pediatric follow-up. And long-term follow-up of the patients has become possible due to the kind of involvement of the Foreign and Commonwealth Office. So we gained a huge support from the British Embassy for this project. And this is the status of the follow-up of this cohort. We have already collected almost over 700 questionnaires, and we will be ready to provide this also unique data on long-term follow-up, that is about 6 months from discharge of hospitalized patients very soon. And lastly, I would like to highlight that all of the above has become possible due to the ISRIC-Sechenov partnership, and has allowed us to distribute the and operationalize the characterization tools, facilitate our visibility as a source of transparent data, and of course contribute to the global effort in collecting standardized data. So the take-home message is to involve medical students more actively into the ongoing research, which can help in the low resource setting that we are put in due to the extremely high demand on doctors and clinical researchers. And that collaboration with ISRIC allowed us to initiate a number of additional projects. And the flagmanship is currently given to the long COVID project that we are conducting. So thank you so much for your attention, and I'm giving word to the next speaker.
Good morning, everybody. Thank you for kind invitation for this great meeting. It's a great pleasure and great honor for me. So my topic will be on non-invasive ventilation COVID-19 and key features to pay attention for. And first of all, I want to say that we should clearly imagine whom to intubate and whom to ventilate non-invasively, because it's very difficult and very beautiful question for us. And we should imagine that reasons for intubation in non-COVID-19 acute respiratory failure is not just problems in lungs. It's problems, complex problems concerning head problems, consciousness disorders like delirium and needing deep sedation like stupor or coma due to sepsis and multiple organ failure. It's some problems with illness, critical illness, polyneuropathy due to sepsis, multiple organ failure. It's diaphragm dysfunction due to multiple organ failure and sepsis, and severe abnormalities of respiratory mechanics. It's increase in chest wall and lung elastance due to many reasons: intra-abdominal hypertension, mediastinal edema, elevated pleural pressure, obesity, and so on. So this complex of problems lead us to intubation of our patient. And we don't consider now some problems with hemodynamics, multiple organ failure problems, which lead us to intubation. And the last 10 years taught us about patient self-inflicted lung injury, one of the main causes for reasons for intubation in patients with acute respiratory distress syndrome. And so I think that COVID-19 RDS often does not meet this criteria, but it's not maybe concerning the patient's self-inflicted lung injury. And the focal loss of aeration, which we can see in COVID-19 RDS and primary non-recruitable lung, which we can see hypoxemia due to shunt, we can see low lung recruitability and no need in high PEEP, and we don't see no excessive work of breathing to overcome elevated lung and chest wall elastance. So typically in primary RDS due to COVID-19, we should use low or high flow oxygen or non-invasive ventilation based on this physiology. Is there a difference for the lungs between non-invasive ventilation and invasive ventilation? For me, it's just an interface when we're talking about primary distress syndrome. And we put on a commentary in the Blue Journal in August, commentary on an article where in Massachusetts, all patients were intubated with PF ratio of 300 and more, and very low mortality, of course. And we put this question, do all these patients definitely require intubation, mechanical ventilation? So is severe hypoxemia in COVID-19 a primary reason for intubation? We can see such patients every day. It's patient with non-invasive ventilation, PF ratio less than 100, 19, and she performs her head dressing in the morning, no problem. It's patient sitting, eating, and so on. So it's non-invasive ventilation with very severe hypoxemic disorder. And we can share our experience on out of ICU non-invasive ventilation. The first wave of COVID-19, you can see here that we include patients who need in oxygen more than 6 liters per minute. Include 61 patients, 44 patients had NIF success. We shouldn't transfer them to ICU. And patients who were transferred to ICU and to intubated, nearly 100% would die. And if you see this table concerning NIF success and NIF failure groups, you can see that no difference in PF ratio between these groups. And hypoxemia is not a reason for intubation per se, as I previously said. And so what about hypercapnia in COVID-19? Maybe it's the reason for intubation. And we should remember that in COVID-19, we have very high alveolar dead space, so we don't believe in PET CO2 in our capnographs. And now we see the patient with NIF failure, 11 days of NIF failure. And the first day after NIF failure, you can see that capnography show us the figure 30, and the arterial figure of CO2 will be 55, 60, 70, and so on. So we saw increased alveolar dead space in these patients. And so we should pay attention to PeCO2 and what minute ventilation is needed to achieve normocapnia. And we use in our practice the ventilatory ratio, a simple tool for prediction of knee failure, which told us about how much minute ventilation needed to reach a goal PeCO2 in arterial blood. And we see that in our patients, it was 2 and more patients who were intubated. And this was in this table in our study concerning knee outside ICU. You see that hypoxemia was not a predictor for knee failure, but ventilatory ratio, minute ventilation was a predictor of knee failure. You can see that in patients with knee failure, this figure was 2 and more, and minute ventilation more than 60 liters per minute. So what should we monitor? We should look at the tidal volume and respiratory rate when we perform non-invasive ventilation. We know that tidal volume more than 10 milliliters per kilo of predicted body weight is predicted for knee failure. And how to assess abnormalities in respiratory mechanics non-invasively is the main question. We should not we should reach this border when to decide when to intubate the patient. And we use this very simple technique. We look at accessory respiratory muscles, and we try to see signs of dyspnea, signs of accessory respiratory muscles work. We use for this Patrick scale, and we make decisions based on 4 and 5 or 5 points of this scale to increase inspiratory pressure or intubate patient. Patient with 5 points should be intubated. Patient with 4 points, maybe we can increase inspiratory pressure, and if it fails, we will intubate this patient. So one of the main interesting features of non-invasive ventilation monitoring, we can see the peak flow and minute ventilation and tidal volume. We can see here that this patient with peak inspiratory flow 80, this patient has a very high inspiratory fraction of oxygen, 100%, not very high inspiratory pressure. This is the knee failure patient, day 7 of NIF and knee failure. You can see another patient with day 5 of NIF and very high peak flow, very high minute ventilation. It's 5 day of NIF, day 5 of NIF. But on day 10 of the NIF, this patient has a decrease of peak inspiratory flow, decrease of minute ventilation, decrease of ventilatory ratio, NIF success. And one more thing that we should mention here is, of course, the rotation of NIF mask. It's very important to not to reach NIF failure. It's my experience. The first day of my epidemic of COVID-19 in working with patients with COVID-19, you see oral nasal mask, small decubitus. Day 4, you can see another decubitus, much more pronounced. And on day 10, I will change it to total face mask, and you can see on day 60 of total face mask, everyday use, we can see nothing on my face. Thank you for your attention. Be healthy and, of course, happy.
Okay. Hello, everyone. Thank you very much for inviting me. It's a great honor and pleasure for me to be here. I'm a pulmonologist, so I would like to present the view of pulmonologist on non-invasive ventilation. So, non-invasive ventilation outside intensive care unit. First of all, I would like to start. How can I move? Oh, sorry. Okay, next slide, please. Unfortunately, yes. First of all, I would like to show you our nationwide analysis about the mortality of patients who are on respiratory support. And so you can see our nationwide data, more than 75% died if they are on invasive mechanical ventilation. So amid increasing concern about the harms associated with invasive ventilation. Next slide, please. There is an interesting to explore the role of non-invasive ventilation in acute respiratory failure in our COVID-19 patients. This picture was taken from the real life hospital experience, hospital surroundings. It's our patients who are in general ward. Next slide, please. So we use with non-invasive ventilation two major modes: CPAP mode and B-level or pressure support mode. But we can unite this mode under one umbrella as pressure support therapy. And between oxygen and pressure support therapy, there is a huge difference, because pressure support in airway can recruit collapsed alveoli and so can increase ventilation perfusion matching and therefore increase oxygenation. It's very important from the pathophysiological point of view. The next slide, please. But at the beginning of pandemic of COVID-19, there was some concerns about NIF as a aerosol generating procedure. And of course, there were some concerns about the virus spread of in aerosol produced by this procedure. The next slide. And initially, many guideline recommendations were against the use of NIV in patients with acute hypoxemic respiratory failure due to COVID-19. At least they were partially based on the concern about the virus spread in aerosol. For example, this is the most respected guidelines of surviving sepsis campaign, and you can see here the place of non-invasive ventilation is only here. You can try before intubation. And so the same situation was as a guideline. For example, in the guideline of World Health Organization, you can see that non-invasive ventilation can be used only in selected case. Next slide. But in real life, during the current pandemic, non-invasive ventilation has been widely used in China and several European countries, also in Russia and in Latin America. Next slide, please. And Ben mentioned these guidelines, the guidelines from NHS. In my opinion, it was the first guideline published in April of this year. And in these guidelines, it was noted that CPAP is the preferred mode of respiratory support. You can see here the yellow zone, and in yellow zone, we can see the important place for non-invasive ventilation in the management of patients with acute hypoxemic respiratory failure. Next slide. Then followed another very important guidelines. This is guidelines from Germany. You can see also here the very important place of non-invasive ventilation. The first step for respiratory support is oxygen, and the second place is CPAP therapy and non-invasive ventilation. Next slide. And this is the guidelines from our university. It's not translated, but you can see here, for example, CPAP is indicated here. So CPAP has a very important place in the management algorithm of our COVID-19 patients. And here you can see our goal of therapy. So our therapy was directed to reduce hypoxemia and to reduce the work of breathing in our patients. Next slide, please. What do we have now? What kind of information, or what the best available published data? Up to date, at least 16 papers were published. I present all this paper here. You can see that almost majority, or to be precise, half of them were from Italy. Of course, all these papers were presented as non-randomized studies. And interestingly, you can see that only one study was conducted in emergency department. Two studies were conducted as in ICU, and all other 13 paper our studies were conducted in pulmonology department, so-called COVID-19 department, respiratory care department in general ward. So the majority of published papers were devoted to the patients who were located outside the ICU. The next slide. And very interestingly, I present here the initial pH ratio in patient before NIV, and you can see that pH ratio varies from 107.8 to 170. So this is very severe patient. According to the Berlin classification, they correspond to the moderate severe RDS. Next slide. Next, Andrei has showed this data. Next, I would like also to stress that pH ratio was not a predictor of NIV failure in our study. Sometimes our patient with pH less than 70 millimeter can avoid intubation. Next. And what about the efficacy of NIV? In my opinion, our pilot study revealed dramatic benefits with NIV. This is the principal picture from our study. You can see that success rate was about 72%, and only 25 patients died in our cohort study. So we can conclude that NIV was highly beneficial in this patient. What about another studies? Next slide. I present here the death rate in red and intubation, endotracheal intubation in blue. And with exception of one study, you can see that the average death rate was about 25–30%, and the average intubation rate was pretty the same, about 25%. So from this data, we can conclude that NIV can avoid intubation. NIV in patients with COVID-19 can save lives. And in my opinion, these findings are very striking. So we can conclude that NIV should be used as a first-line respiratory support method in COVID-19 in patients with acute hypoxemic respiratory failure. Next. Thank you very much for your attention.
Hi, good afternoon, and my name is Dr. Bronwyn Connolly. I'm a senior lecturer in critical care at Queen's University in Belfast, and I'm a co-investigator on the Recovery Respiratory Support trial. And on behalf of the whole team for whom I'm presenting today, we'd like to thank the ESURIC team for the opportunity of presenting the trial today to you. And the trial looks at respiratory strategies in COVID-19, CPAP, high flow and standard oxygen therapy. Just some key pieces of information about the trial. The trial has two chief investigators, Professor Gavin Perkins and Professor Danny McCauley. It is funded by the National Institute for Health Research and is coordinated via the Warwick Clinical Trials Unit. And if you would like further information about the trial, then you can either contact us on the trial email or look at the trial website and find all of the relevant information about the study. Importantly, to highlight, the Recovery Respiratory Support trial is one of the urgent public health COVID-19 studies in the UK, which means that it is prioritised as a trial and has a number of resources directed to support its conduct. And I'd also like to highlight there some of the supporting organisations for the study. So as I've mentioned, the trial is comparing CPAP versus high flow nasal oxygen versus standard oxygen therapy in patients with acute hypoxemic respiratory failure in COVID-19. Ben has given a really detailed background to this in his presentation earlier, which gives a lot of the sense of why this trial was important and why it remains a priority for its conduct. So at the beginning of the pandemic, there were multiple national and international guidelines and recommendations about how respiratory support should be delivered in clinical practice for patients with acute hypoxic respiratory failure secondary to COVID-19. But they were very inconsistent, variable in their recommendations, and often with very minimal evidence. And where evidence was available, it was typically indirect from other populations and of low quality. Some of those recommendations were suggesting CPAP as the first line of treatment. Others were suggesting high flow. And in many cases, it depended on whether or not the patient had potential escalation of treatment. So that really formed the basis for why our trial was commenced, and it was commenced at speed. It was commissioned by the Chief Medical Officer in the UK. Importantly, as Ben highlighted, the very recent guidance from the British Thoracic Society and the Intensive Care Society highlights that stepwise progression of therapy, but importantly, incorporating consideration of recruitment into the trial where possible. And the reason that's really valuable is because we've found from our experience that sites where they are recruiting very successfully to the trial have the trial embedded into their clinical care pathways. So encouraging clinicians to be aware of the trial when they're looking at treatment decisions for patients is incredibly important. So the aim of the study overall is to determine if CPAP or high flow nasal oxygen is clinically effective compared to standard oxygen therapy in patients with confirmed or suspected COVID-19 disease. It's an adaptive group sequential design randomized control trial where we're looking to enroll a maximum of 4,000 or just over 4,000 patients. But the planned interim analyses that are part of the study design will inform how we continue with the trial, and we may not need that total target sample. We're recruiting in more than 60 sites across the UK, and we'll be looking to recruit over a period of 12 months. The primary outcome is a composite of intubation or mortality within 30 days, and we report a number of secondary outcomes that are related to each of those components of that composite primary outcome, and a number of other secondary outcomes relating to clinical and adverse events. In terms of the patients that we are enrolling into the study, we are including adults who are admitted to hospital with either suspected or proven COVID-19 disease, who require FiO2 requirements of more than 0.4 and who are saturating at less than or equal to 94%, and importantly have a plan for escalation to intubation if required. We are excluding patients who have a planned intubation progressing to mechanical ventilation within 1 hour, who have known or clinically apparent pregnancy, where there is any contraindication to the treatments under investigation, if there is a decision not to intubate the patient, and where there is equipment for both CPAP and high flow nasal oxygen are not available. So we've taken a very pragmatic approach to designing the study and to make it as easy as possible for our sites to enroll patients. And so the nature of the randomization in the trial allows sites to enroll patients if they only have one of either CPAP or high flow nasal oxygen available. At the start of the pandemic, there were a number of concerns around equipment availability, resources, oxygen supplies. And so we have this function available within the trial where if sites only have one treatment option available, then patients can still be randomized. And obviously, if they have both options, that's fine as well. This is a schematic of the timelines of the trial progress so far, and I won't go through it in minute detail, but it's suffice to say that this has been a study that has been conducted and set up at speed. You'll see from the first time points where the draft of the protocol was available at the end of March to our first site opening and our first patient recruited 9 days later on the 9th of April. And we now have 75 sites open, with 563 patients recruited, and our first interim analysis is coming very shortly. It's really important to highlight here, the team effect of everybody putting together on this trial, but importantly, the fantastic work of the Methods Centre and the Warwick Clinical Trials Unit, who have delivered the setup of this trial at incredible speed. So credit to them in their work for this. And just to acknowledge the trial team there's a number of people involved in the study. I've highlighted the fantastic work of the Methods Centre, but also to acknowledge the support from the NIHR who are funding this trial, and also our support for its delivery at site level via the Clinical Research Network, which has been invaluable. And finally, I'd like to round off by acknowledging the local site teams and the clinicians and researchers who are working incredibly hard at site level to recruit our patients, and the incredible contribution of our patients and their families who are taking part in this study in very difficult circumstances. So we're incredibly grateful and recognise the contribution of everybody involved in answering this very important question. So happy to take questions at the end if anybody has any. Thank you.
Okay, may I move on to the next speak? So I'm Armand Desap, and I will discuss with you the frugal approach we tried to set up for respiratory support during the COVID pandemic in France. Here are my conflict of interest. Next. So we had a huge outbreak in the Greater Paris region, as you can see on the slide in yellow, during the first outbreak, with many patients coming to the hospital, but also into the ICU. So we were in shortage of ICU beds and ventilators, and tried to settle a frugal approach. Next slide. The idea was that despite increasing our ICU beds in the hospital from 45 to nearly 80, we weren't able to handle all the outbreak. We had a lot of reinforcement personnel coming from regions in France which were less affected, here in yellow, but all this was not enough. Next. So we tried to build a frugal innovation. As you can see in this paper, the main principle of frugal innovation, if it is applied to critical care, would be to have a driver which is what do we need, but not what should be nice to have, as usually done in conventional innovation. The process here is bottom to up, but not top to down. And here the constraints, like the number of patients, is conceived as an opportunity, but not as a barrier. So the idea is to have core capabilities focused on functionality, and having a solution which is really adaptable, simple, user-friendly, easy to use, and which has a reduced cost, allowing it to be applied in all settings, but not only in high-income settings. Next slide. So for this specific question, the idea was to have a frugal non-invasive ventilation support, which can be set up in intermediate care units as a bridge to intubation, or to delay intubation in a number of patients to allow ICU not to be overwhelmed. The second need was here to minimize the risk of aerosol dispersion to the healthcare personnel. Next slide. So we tried to work on the Bousignac valve, which was invented by this guy. The idea of this valve is very simple. The oxygen molecules arrive in microcapillaries, and they are accelerated, creating a zone of turbulence, which will act as a virtual valve between the lung and the open atmosphere. Next slide. So you can see here if the film can be activated by clicking on it. I don't have the hand to do that. Just clicking on the, thank you. You can see that if you don't use a filter on a face mask with a Bousignac device, you have a lot of aerosolization. But if you add a filter, as in this experiment we made, you have a significant reduction of the aerosolization. Next slide. But by adding this filter, we weren't sure that the mechanical properties of the virtual valve are maintained in terms of pressure delivered. So next slide, we performed a bench study by measuring with the addition of the filter what were the pressures delivered to the mannequin. And we also did some measurements in few patients. Next slide, please. So we observed that as in the classical virtual valve, the increase in oxygen flow was associated with a gradual and linear increase in the pressure delivered. And this was true for the mannequin in brown, but also in patients. These are the green circles. Next slide. So reassured with that solution working with safety, we tried to build up intermediate care units which were functioning with non-ICU doctors and non-ICU nurses. So we had to train them to this technique they didn't know, and we had new constraints for that training phase, which were the social distancing that we had to have to avoid hospital clusters, and we also lacked trainers. So we decided, next slide, to have a video tutorial built up, which was very short, very pragmatic, and realized in a real ICU room. And we posted, next slide, this video on a massive open online course in France, but the course was also translated in many languages because we had some demands from English speaking and Spanish speaking. So the success was important, and more than 50,000 learners around the world completed that training. Next slide. So we also did a retrospective study to see how things went on in these intermediate care units. Within 1 month, we had 55 patients in these units that had the CPAP system. As you can see on the graphs on the right side of the slide, the respiratory rate tended to decrease with the CPAP, while the SpO2 increased. So we had physiological effects. All patients having admission in these units had an indication for ICU admission, but there was no place in the ICU, so they went to that intermediate care unit. And nearly half of them even had an immediate indication for intubation. Next slide. You can see that more than 1/3 of these patients improved, while the 2/3 finally got intubated a few days later. But ICU admission was avoided in 1/5 of these severe patients. And within the subgroup of patients with indication for intubation, more than 1/3 finally didn't have intubation. Next slide. So this technique may prove useful in avoiding a proportion of patient intubation, and also in delaying intubation. And this can be important in the context of a massive outbreak because that will reduce the number of patients needed to be transferred to other hospitals. And you can see this report of another Greater Paris hospital which set up some CPAP in intermediate care units. It is the black line allowing a reduction of transfers, red line. Next slide, please. Another option could be the helmet CPAP, but here you really need to be used to that. When you present helmet CPAP to an Italian nurse, she recognizes it because the Italian really use it on a routine basis, but a French nurse would think you are talking about a cosmonaut. So the training here is important. And another drawback of this approach is the need for very high levels of oxygen flow, more than 60 liters per minute in very severe patients, making that not a solution that can be implemented in places where the oxygen availability is one of the constraints. Next slide. Obviously, high-flow nasal oxygen is a solution widely used for these patients with preliminary results which are encouraging, as in this study from a Parisian hospital. But during the first outbreak, the device availability of high-flow nasal oxygen was low. And here also we need high levels of oxygen, 30 to 60 liters per minute, making this complicated, especially in low and middle income countries. Next slide, please. So to conclude, either CPAP or high flow may reduce or delay intubation during massive outbreaks. The randomized studies ongoing will give us a definite answer, but from a frugal perspective, some work needs to be done using virtual CPAP valves with addition of filter because they may be useful in many situations, including constraint situation in low and middle income countries. Thank you for your attention.
Hi, everybody. My name is Tim Baker. Thank you very much for inviting me to speak at this forum. I'm a consultant in intensive care medicine and a researcher, currently based in Dar es Salaam, Tanzania. And those are my affiliations there. And I think it's very fitting to follow on after Professor Armand talking about frugal approaches, because I'm going to go one step further and talk about the most basic things and how we shouldn't forget them globally and particularly in low resource settings when we're managing very sick COVID patients and others. So I'm going to talk a bit about critical illness in general. What's the burden of critical illness? What care for critically ill patients is like globally and in low resource settings. And speak a little bit about a new concept called essential emergency and critical care. So critical illness, something we all talk about all the time, particularly in 2020 for understandable reasons, but it's actually rather a slippery term to define. This is a working definition that we use, which is that critical illness is a state of ill health with vital organ dysfunction, a high risk of imminent death if action is not taken, and also an important component is there is some sort of potential for reversibility. Basically, it is the most severe form of illness, irrespective of condition, irrespective of specialty. In COVID, this classic triangle that came out of the beginning of the pandemic from China said that 20% of patients have severe or critical COVID. In terms of the definition of critical illness, I would say both of these groups are actually critically ill. They all need urgent care to avoid high risk of dying. So 20% critically ill. If we look in the world, there's very little numbers about the numbers of critically ill patients. Instead, most data is in disease specific conditions. So for example, there's 11 million deaths due to sepsis, but some estimates have ranged around about 30 to 45 million cases of critical illness annually from all different conditions. At the beginning of the COVID pandemic, there was different modeling done. And for example, in Nigeria, it was feared that 0.7% of the whole population could become critically ill just from COVID. We've done a study ourselves. This is pre-COVID to try and understand how many patients within hospitals are critically ill, where we took the vital signs of all hospital patients and used the simple definition of critical illness, which is the presence of one or more danger signs, so a severely deranged vital sign. We've done this in many countries across the world. In Malawi, this data here found among the over 1,000 patients who were very young, that's notable for low resource settings, that 18% of them were critically ill. So quite a large burden of critical illness in hospitals in Malawi. And notably, more than 9 out of 10 of these patients were on the general hospital wards, not in ICUs. So an important point is that critical illness and the care provided to them, the critical care, is in many settings not the same as intensive care on ICUs. What sort of care are we able to provide around the world? Well, if we use Malawi as a case study, we've just said there is a large burden of critical illness. Unfortunately, in the country of 19 million people, there's only currently 5 specialists in intensive care and very few ICU trained nurses. The intensive care that we are doing in Malawi is without arterial blood gases, often without capnography, without portable x-rays or CT scanning, this sort of frugal approach or low resource approach to intensive care. We're not able to do many investigations, and we suffer from issues like supply breaks in oxygen, electricity problems, and even equipment breakdown. There's substantial deficiencies, has been shown in other research in terms of numbers of beds. In Kenya, before the pandemic began, it was estimated there was 256 ICU beds, and Malawi only had 25. This can be compared with England, which had over 4,000, and Germany, 28,000 ICU beds. This means we have to think that care for critically ill patients in these settings will inevitably be rather different from the care in high resource settings. And maybe we even need to think that coming down to the things that have been the topic of a lot of talks today, of high flow nasal oxygen or CPAP, may be a challenge to do in a safe way. A key issue is the oxygen supply, and in Malawi and Kenya, only about half of beds in hospitals even have possibility of giving oxygen. So figures like the ones Arman said of almost 60 liters per minute of oxygen for a high flow helmet CPAP may be rather difficult to accomplish in these sorts of settings. We try and look at the care, again from this study we did in Malawi, how much care are we providing for the patients. So of these, on this point prevalence study, we found that 45 of these patients were hypoxic at that point in time, and those went on to have a mortality of 22%. Interestingly, or rather shockingly, only 5 were currently receiving oxygen, which means we had an unmet need. Where did the slides go? Can the slides be restarted? Sorry, I'm unable to. Here we go. So move forwards a bit, please. Thank you. There we go. Back one. There we go. So there was an unmet need of care for hypoxia of 89%. Similarly, for hypotension, 9% of patients had a blood pressure less than 90. They also had a high mortality rate, and 9 out of 10 of them were not receiving IV fluids at that point. For unconscious patients, 17 patients were currently unconscious in the hospital. Remember, most of these are outside the ICU, and half of them did not have a protected airway or were placed in the recovery position. And for a respiratory rate more than 30, none of those patients were receiving oxygen. So there's a large unmet need for these basic critical care things. Forwards one slide, please. Again. So we've come up with this concept of essential emergency and critical care, which is a new concept and a systems innovation defined as the care that all critically ill patients should receive in all hospitals in the world. And it has an added emphasis now in the COVID pandemic, which really is a crisis of critical care and a crisis of EECC. We need to expand these sorts of basic essential therapies that define the minimum standards of care all over the world for this huge surge of critical illness we have. And it's all based on the standard things we know so well about airway, breathing, circulation. Next slide, please. It's good to see it in this conceptual way, I think, is it kind of forms the basis or the floor of care, the most simple things that can be all across the hospital, the emergency unit, in the theatre, in ICU, or the ward, contains all of the most essential, most simple forms of care for critical illness. Above this, you can then have the more advanced forms of care, the intermediate and advanced, where we're talking about the non-invasive ventilation, the mechanical ventilation, vasopressors, and so on. So the EECC is this base level which all patients should have. Next slide, please. This is one intervention study we did in an ICU in Tanzania, where we introduced a vital signs directed therapy protocol. It's a bit like goal directed therapy, but on a simple level, where the nurses could check the vital signs as they were doing, but then the hospital empowered the nurses to carry out these simple life-saving actions like providing fluids, oxygen, changing the patient position, and so on, when they identified critical illness. And what we found is this piece of paper, this introduced protocol, did increase the acute treatment of very sick patients and actually reduced mortality for the patients in shock from 90% down to 70%, which gave the numbers needed to treat of just over 4. So we can do basic things, it does work, and it does change outcomes. Next slide, please. To understand the ECC, if you look at the top picture, we want all of our critically ill patients to survive. And to get there, they need to be stabilized. And to be stabilized, they need good coverage, effective coverage of these actions in ECC. And the ECC has 2 domains of identification. If we don't identify the patients, we will not be able to give them good care, and the essential care. And both of those involve good clinical practice, which requires the hospitals to be ready to provide this care. And this model allows us to do a bottleneck analysis where we can investigate different settings and find where are the bottlenecks for providing this effective coverage of care. Next slide, please. One more step, please. Current project we're working on is in the COVID-19 pandemic is trying to determine the optimal methods and also the cost effectiveness of scaling up and providing quality care to critically ill patients in hospitals. And the 2 countries we're working in are Kenya and Tanzania. We'll be doing policy analyses. We have lots of surveys and questionnaires ongoing to understand the care, understand the impact through the pandemic. What should we be doing? Next slide, please. Just for examples of the clinical practice we're looking at is, are the hospitals doing triage, both at arrival to hospital, in the wards? Are they identifying and then labeling critically ill patients? Are they increasing observations when a very sick patient is found? Next slide, please. And for care, are they doing the ABC care? Is the airway being managed? Are they providing simple oxygen therapy and IV fluids? Next slide, please. All of this work fits into this. There's a current movement in global health about the quality of care in health systems. One more step, please. This was a Lancet commission a couple of years ago that found that across settings in the world, there is substantial amounts of poor or inadequate care. And actually, quality of care has become a bigger problem for the world than access to care. If we would improve the quality of care globally, we could save over 8 million lives. And an emphasis needs to be on research for how we transform these health systems from low to high quality. Next slide, please. Impact, one more step, please. If we, what our vision is, next slide, please, or next step. We want a world where no patients are dying in hospital of a cause that these sorts of basic things could prevent. And one more, please. And as a very, very rough modeling estimate, if EECC could prevent 1 in 10 deaths from critical illness, it has a potential of saving 500,000 lives every year. Next step, please. Final slide, to take home, critical illness is a very common thing globally. If we want to have a real world impact all over the world, particularly in low resource settings, we must make sure that we provide the essential care to the critically ill patients. This involves focusing on scaling up basic oxygen and providing this good oxygen supply to the patients. And if we do this, we have a huge potential for averting deaths. Next slide, please. Thank you very much.
Tim, thank you very much. That was a selection of superb talks from all our speakers. So I'd like to introduce or ask everyone to turn their cameras back on and ask if anyone has any questions. There's a few that have been mentioned in the question and answer box, which I'll come to in a minute. But I think it's the section has highlighted that management of COVID-19 in different settings across the world is different, but the use of non-invasive has become much more consistent in a number of different countries. I think non-invasive is new to us in severe acute respiratory infections, and it certainly does seem to appear to benefit many patients. However, I think it's important to remember that non-invasive is not benign. It comes with its own complications, and actually how is it that we're able to identify those people for those who may not benefit from non-invasive. So just looking at the questions, so from Kaz Sampson, many thanks to the recovery RS teams for their hard work. I think this is such an important trial. The million-dollar question facing all of us in ICU currently is when to intubate from high flow nasal oxygen or CPAP. And I agree that is completely the question. So there are definitely people who can benefit from this, and we're very happy with sort of the less sick patients. But when you have a patient sitting in front of you who's just getting a little bit worse each day, at what point do we then admit that non-invasive is not succeeding and we need to move to intubation? Bronwyn, do you want to answer the next part of that question?
Yeah, thank you. Thanks, Anne-Marie. So we leave the decision to intubate a patient at the clinical discretion of the local team managing the patient. So that's not kind of formally protocolized in any way in terms of how long patients should try on their allocated treatment. So we've tried to collect as much data as we can versus burden of data collection in the current context that will allow us to answer the main question. So we're not necessarily looking at trying to predict, identify those patients and predict those patients who might fail either high flow CPAP or oxygen therapy. So we may be able to explore some of that and kind of identify patients that might have been coming through when we see the data in the final data set, but we haven't set it up in that way to be able to do that. And how many days of support should invasive ventilation be strongly considered? I'm assuming you mean how long should patients try before being intubated? And again, we don't enforce anything like that within the trial. It's very much locally dependent on the clinical team. So I appreciate that doesn't necessarily give a very hard and fast answer to that, because it's not something that we felt that the trial can answer necessarily in that context.
Lovely, thanks, Bronwyn. So Andre, we were talking offline about this very difficulty of being able to identify those patients who are failing on NIV. And I was really interested in your scale, where you're talking about the work of breathing that is what predicts failure or success. I don't know if you could expand on that a little bit.
Thank you. For me, this scale, Patrick scale, on work of breathing and work of accessory respiratory muscles is a reflection of patients' lung and chest wall mechanics. When we talk about primary RDS, like in COVID-19, we talk about primary RDS. So it's we can talk about reflection of lung mechanics and lung elastance as well. So our decision based on is it based on differences in this scale in different NIV modes, depending on inspiratory pressure and CPAP pressure. So when we saw such involvement on respiratory accessory muscles, we try to increase inspiratory pressure, and if it fails, we decide to intubate this patient. If we have large involvement in respiratory muscles, if we can see the indwelling of supraclavicular spaces and so on, and this is will be the reason for intubation, not hypoxemia, but for us it's the signs of patient self-induced lung injury due to excessive load of respiratory muscles and due to high transpulmonary pressure swings. And so for us, it's the tool to decide to intubate patients.
Lovely, thank you. So it actually feeds very well into Stephen's question regarding the mechanism of barotrauma, which I know that you've spoken about in the Q&A panel. Sergey, do you have anything that you'd like to add to that? You've very interestingly said that actually, although there is a lot of pneumothoraces, these patients were on very little respiratory support at the time. Can you think why they may be so prone to lung injury?
Yes, of course. Now we are talking about we are talking a lot about the pneumothorax, pneumomediastinum in the COVID-19 patient. But what's the exact reason? It's very difficult now to judge, because for example, I posted in answer that about more than 30 patients with pneumomediastinum or pneumothorax were on spontaneous breathing. So there was not a pressure as a factor leading to pneumothorax in such kind of patient. And among the whole group of patients with pneumothorax and mediastinum, only about 1/3 of patients, more than 30%, 32%, as I know, only 5% of all patients were on non-invasive ventilation. So, in my opinion, the reason for pneumothorax or barotrauma is not the pressure in terms of non-invasive or invasive ventilation. The reason is the properties of the lung. Also, it's intrinsic feature of RDS associated with COVID-19.
Thank you very much. And I was wondering if we could speak about your valve briefly. I know in the UK there's a lot of resistance to providing CPAP and NIV out with the ICU setting, and the concern of spreads both to staff and to other patients. But this seems potentially a way of managing to reduce the concern of spread of coronavirus.
We had the same fear at the beginning, which is a reasonable fear, because as you saw in the video, if you have no filter during exhalation, you will have a very massive dispersion going up to 2 meters. So I think it is absolutely necessary to have a filter when using that technique. And the bench measures show globally that the pressure is still transmitted with the filter. There is an increase in the resistive work done by the patient, but which is not very important for the more severe patients.
Thank you. So Tim, your experiences in Malawi are very different from these discussions with NIV. And actually, your mortality rates seem significantly lower than we've seen, certainly in the UK. I think this is possibly slightly off topic, but I wondered if you had any thoughts for why that might be.
Do you mean the mortality rates from COVID?
Yeah.
Yeah. I mean, I think it's a question that's very high up the list on lots of people's agendas, and isn't really a good answer. There seems to be a lot less severe disease from COVID across Africa. Of course, maybe one of the explanations is the young population. So there is median age in lots of African countries is about 16. So half of the population are children. But then there are many other theories about what it could be: the climate, the way that people live, outside lifestyles, lack of comorbidities, maybe other factors, cross immunology issues and things like this. So no very good answer, I'm afraid.
Well, I think that's certainly in the UK. We certainly have a very elderly comorbid population, which I think impacts very much onto the mortality that we're seeing. I think that is all the questions answered, and it is 10:30, which I think is a perfect time to draw this to a conclusion. So I'd like to say thank you very much to all our panelists and to the ISRIC Forum for hosting this. I think NIV in severe acute respiratory infections is here to stay, and it certainly can benefit some patients. And I think the challenge will be identifying those in whom actually NIV may delay the opportunity to have lung protective ventilation from intubation and ventilation. So thank you very much, and I hope you'll join us for our next session as well. Thank you. Goodbye.
Thank you.
Bye.
Thank
Thank
you.
you very much. Thank you.
Thank you.